Okay, good morning or good late morning, everybody. As people are filing into the room, into their seats, I'd like to begin the session and introduce myself. I'm Annette Sohn. I'm the Director of Treat Asia, AMFAR in Bangkok, Thailand. And to my right is?
So I'm Mo Archie. I'm a pediatrician, pediatric infectious diseases from University of KwaZulu-Natal in Durban, South Africa.
Thank you. So what will happen is I will go ahead and introduce the first three speakers, and then Dr. Mo will introduce the last three speakers. And we've been very careful with them. They will tell you multiple emails saying, you only have 10 minutes, you only have 10 minutes, because we want to encourage questions. And this is something that the IAS receives in feedback, that the audience really appreciates the opportunity to engage with the speakers and ask about the work that's presented. So we'd like to suggest that if you do have questions, please feel free to share those after the talks. If we run out of time, our speakers will be here afterwards and can answer questions directly with you in conversation. So our title of our session today is Children and Adolescents, Issues in the First and Second Decade. And we're very pleased to be able to bring this focus on children and adolescents. And I think increasingly every conference that the IAS organizes that goes by, the word adolescent is probably spoken more frequently at each conference. And I think that's a good thing, and certainly something that the pediatricians and other people taking care of young people in this audience appreciate and perhaps feel was a long time coming. But I think we're getting pretty close to being on the same page now in wanting to prioritize the issues of children, adolescents, and young adults. And so the first speaker that we have today is Dr. Harriet Bitimwine from Baylor College of Medicine and from Kampala, Uganda, and she's going to give her presentation for us. Dr. Harriet?
So good morning, everyone. I'm making a presentation entitled Maximizing Targeted Testing to Improve HIV Yield Among Children and Adolescents in Rwenzori region in Uganda. I have no conflict of interest to declare. Uganda is in East Africa. It has a prevalence of about 7.3%. This is our work from a project in the Rwenzori region, which is in the mid-eastern western region of the country. And as you see on this map, the Midwestern region has a prevalence of 0.4%. That was in 2011 by the Sero survey. This is work from our project in that region. And at the time we started that project, the coverage for ART for children under 15 was 32% compared to 52% among adults at that time. And we thought that that was partly attributed to low identification of children. Specifically for adolescents 10 to 19 years, in a survey done, it was 1.9% positivity. In this particular work, yield will be used in the same way to mean positivity. And in the district health information system data for the region, for children below 15 years, the yield was 0.7% at that time, and for adolescents, it was 1%. Against this background, Baylor Uganda implemented targeted testing service models for children and adolescents, and in this, the children were those 18 months to 19 years in the period of Jan to March 2016. The models were aimed at improving HIV testing yield because we thought this would be critical in closing the gap in the first 90. The models were largely 4, and one was HIV testing outreaches to OVC dwelling homes. These are homes for orphans and vulnerable children. They included remand homes, orphanages, and some children's homes. We also conducted Know Your Child status campaigns. Know Your Child status campaigns are campaigns conducted at the health facilities where we do open invitations to index clients to bring in their untested children for testing. We also conducted targeted outreaches to KP's children and priority populations children. In particular, we used peer leaders to reach out to female sex workers, and we tested their children within their preferred choice of location in their community. The fisher folks, we also used the beach management units and peer leaders to be able to reach out to the fisher folks within our catchment areas, and they brought their children for testing within their locality. Tea plantation workers, the Rwenzori region, the main source of economic work is largely tea growing. And there are quite a number of employment clusters within the tea plantations. And the tea plantations have a largely high prevalence in that area. So we reached out to the peer leaders within the tea plantations and tested their children within that very community. We also conducted evening testing. This was through established evening testing points within the outpatient departments of the public health facilities, where testing was provided between 5 to 7 p.m., and the interest group was adolescents mainly. What were our results? Our results showed that the largest, about half of the people we reached with this testing were adolescents out of the 4,000 that we were able to test in that period. And the majority of the adolescents that were able to test came through largely the evening testing and Know Your Child status campaigns. When we looked at the proportion of adolescents that were reached specifically in the evening testing reached the intended group, and that was adolescents. 90% of those reached were adolescents 10 to 19 years. What was our HPV testing yield that we got? The testing yield was 0.4 for the age group below 5 years, which compares well with the 2011 indicator survey for Uganda, which was 0.4 for that region. But the older children, for which we had no data in previous surveys, only program data, we got 1.6%, and adolescents was 1.1%, and the older adolescents, 15 to 19, we had a higher yield of 2%. But overall, from all the testing models, the yield was 1.1%. When we look specifically at the groups, initially we had lumped our models into 4, where children of KPs, PPs were all lumped together. But when we're analyzing the data, we realized there were differences between the different groups of the children of the KPs and PPs. For OVC dwelling homes gave us the highest yield with about 2.2%, but we also had a small denominator we're working with. Evening testing, we saw we had a yield of 1.9% from all the children and adolescents in that model. And for children of sex workers, about 1.6%. We learned that some of the children of the sex workers were also sex workers themselves, in particular the adolescents. For the fisher folks, it was 1.1%. We had never known what it was before. And Know Your Child status campaigns in this particular piece of work showed us that we're getting less and less numbers compared to previous years when we would reach even 3 and 2% in that model. From tea plantation workers, you see even the number was small, 214. We stopped it a little earlier because when we tried to do quite a number, we never got any child positive or adolescent in those communities. We looked at the differences between the sex, and we saw that largely in evening testing, it was majorly the females that were positive. And I think everybody would want to know what proportion were females in this group. And it was more or less a 50%. So there were 54% females in this group, but we see more than double the positivity among females in the evening testing And much as KYCS also reached a significant number of adolescents, the yield was much less, which kind of showed us that most of the people in there are already living with HIV and have already tested their children. And we are seeing the older children, the adolescents, more positive in the evening testing. In Uganda, age of consent for testing is 12 years, and that allows the adolescents to come on their own. In conclusion, we concluded by saying that the National Pediatric and HIV Testing Program could benefit from scaling up the implementation of targeted testing, scaling down testing for children in tea plantation work, and also KYCS. This has informed our program. We have continued to do index client testing, but in a different way. We are no longer doing open invitations and waiting for a campaign. HTS for children in OVC dwelling homes and for children of female sex workers and fisher folks, and providing testing for adolescents during flexi time of their choice. In our particular context, it was in the evening, should be scaled up to be able to increase the yield. Thank you very much.
Thank you, Dr. Harriet. We have time for questions now. If we could have the lights up in the main room, and I believe, I'm not sure if there are microphones. If you could please go up to the microphones. There are 4 in the room, and we'll take the first question there. And please introduce yourself and your organization.
Marcel Yotebien, Ohio State University. I'm curious, for the yield you find about less than 5 years, it was 0.4 and jumped immediately to 1.6 among 5 to 10 years. How do you explain that? I would have expect to see a higher yield in younger children that drop progressively as the age go forward. Thank you.
Yeah, thank you very much. I'm sorry, I thought there were more questions coming and I was waiting. Our thinking was that because of the targeting, we are able to get the older children through the different models. But in the younger ones, we also saw people bringing in a lot more children that were not targeted, but because they belong to those communities. And we also thought that possibly it's because we have had lifelong ART and we are seeing fewer children who are younger, who are infected, but there are pockets of children in certain age groups that still remain there, and unless you do something differently, you may not get them, because they may be long-term progressors and they are not actually coming out as sick children, as you may think.
And maybe if I could ask a question while somebody's coming up to the microphone. You had mentioned that some of the orphans in OVC dwellings may have already been known to have HIV.
Yes.
For the evening testing, were all of those unknown HIV status testers or first-time testers?
All the evening testing that we analyze, we are not able to tell whether they were first time or not first time, in the sense that it's their first HIV test, but it was the first time they are knowing their HIV status as positive.
Just to say, so as the only male on the stage, obliged to ask, so where were the men? So and the one major issue is trying to get men to test. And we'd assume that evening testing will be able to get more men to be tested. So where were the men during the evening?
In the evening testing, when we looked at the data only for adolescents, we found that 54% were girls and the rest were boys, so we thought it was fairly equal. We also have a number of older people, but because our work was largely to do with children and adolescents, we didn't put them in our final analysis, but we have some proportion of men coming in at that time.
Okay, I think the three remaining people who are standing, if we could go ahead and start with the microphone here in the center, and then we'll switch.
Thank you. My name is Dr. Kechi Achebe, Save the Children, Washington, D.C.
I'm just wondering, to the first question again about the positivity among the 0 to 5 compared to 5 to 10, or less than 5 compared to 5 to 10, how the PMTCT program correlates with this. I mean, when did Uganda take on option B+, and could that be a reason for, the success among the 0 to 5? Was that looked into?
Yes, it's one of the things I said earlier, because we've had lifelong ART since 20. Cordelia, you can remind me, we've had lifelong ART. We first had option B, and then we moved to lifelong ART in 2012. So the children who are less than 5 years, most of them, if their mothers were already known or got known, they were able to get ART.
Sure, thank you. I'm Marianne Ombija. I'm with EGPATH, Elizabeth Glazier Pediatric AIDS Foundation. And I just had a question about comparing yield at community outreaches versus in clinic and facility, where sometimes we see yield is actually much higher. So I noticed you keep comparing your results to a 2011 population-based survey, but is there any more current real-time data from the facilities as well that we might be able to see the comparison?
Yes, thank you. I think when our facility data is a mixture of both community and facility-based data, because even the work in our country done under communities is reported in the same system, and in the system we are not able to disaggregate by what particular method the testing was done. And that's why I also talk about our DHIS data as was our baseline, with the 0.7 for younger than 15 and 1 for adolescents.
And final question?
Yeah, Philippe Mselati, RARG, Abidjan, Côte d'Ivoire. Just, have you an idea of the proportion of children infected at birth and children infected by other means over 15? Did you get the question?
Can you separate the perinatally versus behaviorally infected over the age of 15? Is that correct?
We are not able to separate them unless we use proxies.
Yes, proxies is good. Tell me.
I possibly don't have that answer offhand, what the number is.
Thank you very much, Dr. Harriet.
Thank you.
Our next speaker is Dr. Tavitia Sujaritruk from Chiang Mai University in northern Thailand, and she's speaking on behalf of the CALD study group. Dr. Tavitia?
Good morning, ladies and gentlemen, co-chairman, and everybody here. Today it's my pleasure to present this study. The adverse bone health is one of the common non-communicable conditions during the course of HIV treatment, and the prevalence of low bone marrow density, or BMD, score fall below 2 or equals -2 among children and adolescents living with HIV, range from 4 to 8% in high-income countries, up to 16 to 32% in middle-income countries. And there are several factors associated with the bone demineralization in this population. Importantly, adverse bone health during adolescence is critical because it may result in adult osteoporosis and bone fragility later in life. Normally, vitamin D is critical for calcium homeostasis and bone metabolism. During the normal vitamin D status, vitamin D helps calcium absorption in the gut to meet the metabolic demands and that maintain the normal bone mineralization. However, in the situation that the vitamin D is deficient, the calcium absorption in the gut declines, and that stimulates the parathyroid gland to increase parathyroid hormone that helps calcium reabsorption in the kidney and calcium mobilization from the bone, and that results in the bone demineralization. However, the clinical evidence supporting the benefit of vitamin D and calcium supplementation on the bone mineral density among HIV-infected youth is limited. And therefore, we conduct this study to evaluate the impacts of vitamin D and calcium supplementation on the BMD and bone metabolism among perinatally HIV-infected Thai adolescents. And we also hypothesize that the dosage of vitamin D supplement may affect the change of the BMD and bone metabolism. And that's the reason why we supplement 2 dosage of vitamin D, which is the high dose and normal dose. For those got the high dose supplementation, they got 3,200 international units of vitamin D plus 1.2 gram of calcium per day. For those received normal dose supplement, they got 400 international units of vitamin D plus 1.2 gram of calcium per day. This is an ongoing multi-center 48-week randomized open-label clinical trial conducted in 5 pediatric HIV centers in Thailand. We enroll participants aged between 10 to 20 years, had perinatally acquired HIV infection, and had virotic suppression. We exclude those who already received vitamin D or calcium supplement or any pharmacologic treatment for low BMD, medications that may affect bone metabolism, those who have history of bone fracture and pregnancy or breastfeeding. This figure shows you the flow of study procedures. Once we got the eligible participant, we stratified them by their baseline BMD to low BMD or normal BMD. And then they all were randomly assigned to receive either high dose or normal dose supplementation. At the baseline, all participants had a blood drawn for the measure the bone biochemical markers together with DEXA scan. At week 24, they all had a blood draw for the bone biochemical markers measurement. And at the end of the study, they all had a blood drawn and also DEXA scan again. In this study, we measured the BMD at the lumbar spine region using the dual energy X-ray absorptiometry technique, and the C-score falls below or equal -2 defined as low BMD. We also measured the bone biochemical markers, include the bone metabolism-related hormone 25-OHD and intact parathyroid hormone, together with the bone turnover markers, alkaline phosphatase, C-terminal cross-linked telepeptide of type 1 collagen or CTX, which is the bone resorption markers, and pro-collagen type 1 amino terminal propeptide or P1NP, which is a bone formation markers. We used the interim analysis in this study based on the intention to treat analysis and stratified by participant baseline BMD-C score. We used the Wilcoxon rank sum test for the between group comparison analysis and side rank test for the within group comparison analysis. And these are the results. This figure shows you the flow of study participants. During April 2015 to October 2016, 215 participants were screened and 166 were eligible for our study. Among who's eligible, 67 participants had low baseline BMD and 99 had normal baseline BMD. Among those with low baseline BMD, 35 and 32 participants were randomly assigned to receive high dose or normal dose supplement. And during the study visit, 2 of them in each group dropped out, and that resulted in 33 and 30 participants in the high dose and normal dose supplement complete the study visit. Among those with normal baseline BMD, 48 and 51 participants were randomly assigned to receive high dose or normal dose supplement. 1 participant in each group dropped out, and 46 participants in the high dose group complete the study and on-study treatment, and 1 off the treatment due to acne. For those in the normal dose group, 49 participants complete the study and on-study treatment, and 1 dropped out off-study treatment due to the pregnancy. This table shows you the baseline characteristic of our participants. The median age was 16 years. About 48% of them were male. Half of them had virtual clinical stage 3 to 4. And at the time of the baseline, about 2/3 of them had received an NRTI-based ART regimen for about 10 years, and the adherence to the medication was about 80%. And you can see that the characteristic of those in the high dose and normal dose group were not significantly different. This table shows you the baseline BMD and bone biochemical markers. At baseline, the BMD-C score was -1.5, and 40% of them had low BMD. And for the BMD and also bone biochemical markers between the groups, there were no significantly difference except for the 25-OHD level, which seems to be lower in the normal dose group. However, the percentage of vitamin D deficiency or 25-OHD below 20 nanogram per ml were not significantly in both groups. This figure shows you the changes of baseline BMD and bone biochemical markers over the study follow-up based on intention to treat analysis. Firstly, focusing on those with low baseline BMD, and you can see that the BMD C-score was significantly increased from baseline to week 48 in both treatment groups. They were also significantly increased in 1 to 5 OHD and significantly declined in IPTH, alkaline phosphatase, CTX, and P1NP from baseline to week 48 in both treatment groups. For those with normal baseline BMD, you can see that there were no significantly change in BMD C-score in both treatment groups, and they were significantly increased in 25 OHD and decline in IPTH, alkaline phosphatase, CTX, and P1NP in both treatment groups. For the between group comparison analysis, which compared the median change from baseline to week 48 of each parameter between the two treatment groups, there were no significantly difference except for the IPTH. Comparing our study findings to other children's study, which conduct in younger kids, 6 to 16 years, received 1,600 international unit of vitamin D and 1 gram of calcium per day versus placebo for about 2 years. They observed the significantly increase in total body BMD, BMC, and lumbar spine BMD and BMC in both treatment groups, but there were no between group differences, which is very similar to our findings. This study has some limitations. First, there may be potential to the differential measurement errors because we use the open label fashion for this study. Also, because this study we conducted only lumbar spine DEXA scan, we did not perform the total body DEXA scan, which is the gold standard for evaluating BMD in adolescents. This study may have short duration of follow-up, so it may be too early to evaluate the long-term outcomes such as bone. And finally, because we focus on only perinatally acquired Hpv-infected adolescents who have virotic suppression and only Thai population, so our result may be limited generalizability to other populations. In conclusion, with our preliminary results, the lumbar spine BMD C-score was significantly increased in our adolescents with low baseline BMD, who received vitamin D and calcium supplement regardless of dosage. Also, bone biochemical markers were established in our adolescents with low and normal baseline BMD in both treatment groups. However, supplementation of high-dose vitamin D calcium did not show significantly difference in the change in BMD and bone metabolism outcomes compared to the normal dose supplement. And we think that a prospective study with longer follow-up is warranted to confirm our findings. And this is my acknowledgement. Thank you.
Thank you. And people in the back who don't have seats, feel free to take this time to look for there are a lot more seats over on your right side of the room. So this presentation is now open for questions. We have somebody at the first microphone.
Hey, congratulations on excellent work. Amara Iziamama, Michigan State University. I am very fascinated by your results, and part of it may be that I didn't understand one of the slides that showed an increase in bone mineral density parameters, but also a decline in markers of both bone formation and bone absorption. And I'm not sure if I'm correct in thinking that those are in divergent directions.
Yes. Yeah, we find, because in normal process of the bone, actually, I should summarize my findings. Yes, we find the increase, the decline in the bone formation and bone resorption markers. But in the normal process of bone remodeling or bone demineralization, both markers may increase, but the bone resorption outweighed the bone formation. So with our supplementation, we saw that there were kind of re-established or attenuation of both bone turnover markers. That's a good sign for confirm that the bone turnover marker is attenuated.
And now I'm just thinking with you because I'm fascinated by vitamin D and how to think about bone markers and the breakdown and the reformation. Is it possible to look at this in terms of ratio? Should we expect them to be balanced homeostatically so that the formation and the absorption should be relatively balanced, and a ratio of the change could it be informative? I don't know.
Yeah, we can, but still waiting for the full data set analysis to do that. Thank you.
Microphone.
Thank you, the presenter. You kept off the ARVs. I thought they have effect on vitamin D. Can you make a comment, especially tenofovir? Thank you.
Okay. Yes. All we know that tenofovir have very impact on the bone density in both children, adolescent, and adult. And in this study, 40% of our adolescents receive TDF-based regimen. But we will look at that impact of tenofovir on the improvement of bone marrow density in the full dataset analysis. But at this moment, we didn't analyze it yet.
Question?
Hi, thanks for the presentation. My name is Dr. Imran and I'm from Save the Children US. So my question is in your study you compared the people with the low bone marrow density and the high, but in both groups those were HIV positive. So in your design, why didn't you compare the two groups, one HIV positive, the other negative? Because both of them, they were the positive.
Yeah, because in this study we use the BMD C-score, which the C-score is calculated from the normal reference, a normal type population. So, and that's we can kind of compare. Is that correct?
Yeah, but my question is instead of having both the groups positive, one group could have been HIV negative and the other one's positive. So, you maybe obviously, as you said, one of the limitation of your study was that you cannot evaluate the long-term outcomes because the period was very short.
Okay, I got it. So yeah, you mean we should have normal control, right? Yeah, in this study we didn't have that. So maybe we will have to compare our result with previous literature which conducted in normal population. It's our limitation, thank you.
So maybe another option would be to include behaviorally infected children and include our adolescents into the study and follow them up as a control arm.
Yeah.
So maybe my question is, was there anything at baseline in terms of either clinical or history that differentiated the children that were either designed as being low BMI or normal BMI that would help to identify these kids?
Actually, we did that, and we see that there were no significantly difference in terms of BMI at the baseline.
Or BMD?
BMD at the baseline, yeah. Sorry.
But other risk factors between those two populations?
Yeah, we measure both the calcium intake, the physical activity level. Yeah, there were no significant difference at the baseline between groups.
Thank you very much, Dr. Tawitia. Our next presenter is Dr. Amy Slogo from the University of Cape Town Center for Infectious Disease and Epidemiologic Research in South Africa, and she will be presenting on behalf of the CIPHER Global Cohort Collaboration.
Thanks very much, Annette, and to everybody here this morning. It really is my pleasure to present this work on behalf of the CIPHER Cohort Collaboration Adolescent Project team. And the authors have no conflicts to declare. So last year in Durban at World AIDS 2016, we shared the first results from the CIPHER Cohort Collaboration Adolescent Project. And this was a multi-regional analysis of more than 38,000 adolescents living with perinatally acquired HIV, 79% of whom were living in sub-Saharan Africa. And even after accounting for marked baseline differences, and in the context of probable under-ascertained mortality in sub-Saharan Africa, adolescents in Africa had a 2- to 4-fold greater hazard for mortality when compared to adolescents in Europe, North America, and South and Southeast Asia. Sub-Saharan Africa is a complex region. It's marked by diversity and inequality. It's also home to 80% of the 1.8 million adolescents aged 10 to 19 years living with perinatally or horizontally acquired HIV, and 14 of the 15 countries with the highest burden of adolescent HIV. Progress in scaling up diagnostic and treatment interventions has been far from uniform across the continent. And furthermore, although AIDS-related deaths in younger adolescents have started to decline in a number of high-burden countries, they continue to rise in others. In pursuit of the Sustainable Development Goals, and particularly achieving health for all at all ages, as well as reducing inequality within and between countries, we wanted to understand how outcomes differ for adolescents living with perinatally acquired HIV within Africa. And thus, the primary objective for this analysis was to compare the characteristics and outcomes, specifically mortality, transfer out, and loss to follow-up, of adolescents living with perinatally acquired HIV, or abbreviated as APH, by country income group within sub-Saharan Africa. APH were defined as HIV-infected children who entered care before age 10 years as a proxy for perinatally acquired HIV and had at least one visit beyond age 10 years. So this analysis only includes children that have survived to at least 10 years of age. Adolescents were further considered as lost to follow-up if their last contact was more than 365 days prior to database closure. Through the SAFA Global Cohort Collaboration, individual retrospective data from 12 cohort networks across 5 regions of the world were originally pooled. This sub-Saharan Africa analysis includes data from 7 networks representing 25 countries. Characteristics were compared by country income group at key time points, being the first visit, antiretroviral therapy start, age 10 years or entry into adolescence, and at the last visit. And World Bank country income group designations were used for the median year of first visit for each country. Outcomes were compared as cumulative incidence, calculated by competing risks analysis, to estimate mortality in the presence of high rates of transfer, out, and loss to follow-up. And mortality was further compared across country income groups by survival analysis using Cox proportional hazards models. So over 30,000 adolescents from 25 countries were included in this analysis. 20 of the 25 countries were designated as low-income countries, shown in orange, and 75% of the adolescents came from these low-income countries. The lower middle-income countries are shown in blue, and they are Cameroon and much smaller Lesotho and Swaziland, and they represented almost 5% of the adolescents. And then the upper middle-income countries included Botswana and South Africa, with almost 20% of the included adolescents. This cohort accumulated a total of more than 78,000 person-years of follow-up between 10 and 19 years of age. Almost 2/3 of adolescents were born in the year 2000 or later, but birth year ranged in this cohort from as early as 1990 to as recently as 2005. So just to orientate you to this series of graphics to come, each cluster represents a key time point. So on this side, first visit on the left, antiretroviral therapy start in the middle, and last visit on the right. And within each cluster, the country income groups are represented by different colors: low income in orange, lower middle income in blue, and upper middle income in green. This slide shows the median and interquartile range for the age at these key time points. And the red dashed horizontal line is just indicating age 10 years for ease of reference. And we see that the median age at the first visit for the entire cohort was just over 7 years and 7.9 years at antiretroviral therapy start, and was just slightly lower in upper middle income compared to lower and lower middle income countries at these time points. Median age at last visit was approximately 12 years of age, with very little difference between country income groups, indicating that this is largely a young adolescent cohort. The median CD4 count at ART start, shown in the second cluster, was close to 300 for all country income groups. However, the mean CD4 count change between ART start and last visit was greatest in lower middle income countries at 463 cells per microliter increase between ART start and last visit. Similarly, WHO height for age Z scores were very similar across country income groups at the first visit and antiretroviral therapy start, with the median Z score below -2 in all country income groups, indicating that the majority of these children were already stunted by the time they started ART. There was some improvement in height following ART start in all country income groups, but adolescents in upper middle income countries experienced a much larger improvement in height, a mean of almost 0.5 Z scores between ART start and last visit. This slide shows the cumulative incidence for the outcomes between 10 and 15 years of age. So the cumulative incidence for mortality, shown in blue, was very similar in low and lower middle income countries in the left and middle panels at 3.5 and 3.9% respectively, and was lowest at 1% in upper middle income countries on the far right. However, upper middle income countries also had the highest incidence of loss to follow-up at almost 14% by 15 years of age. By survival analysis, in reference to upper middle income countries, adolescents in low and lower middle income countries had a threefold elevated hazard for mortality. Adjusting for baseline characteristics, the mortality hazards increased somewhat when including only complete cases, as shown in Model 2, and decreased somewhat when including all cases with multiple imputation for missing CD4 weight and height measures, as shown in Model 3. Restricting only to adolescents that did ever receive ART made very little difference to the relative mortality hazard across country income groups. And adolescents in low and lower middle income countries that did receive ART still had at least a 2.5 to 3-fold elevated hazard for mortality compared to adolescents in upper middle income countries also receiving ART. In conclusion, the current generation of adolescents surviving with perinatally acquired HIV in sub-Saharan Africa largely did experience improvement in immune status and growth, despite starting ART well into childhood. Even when receiving ART, though, inferior growth improvement and higher mortality was observed in adolescents in low and lower middle income countries compared to upper middle income countries, signaling the role of factors beyond the ART program in determining the health and well-being of adolescents with perinatally acquired HIV. Without broader national capacity development in low and lower middle income countries in sub-Saharan Africa and measurable progress towards reducing inequality within and among countries, outcomes for adolescents in low and lower middle income countries are likely to continue to lag behind those of their peers in upper middle income countries in this region. We do recognize that the differences that we've seen in outcomes by country income group may represent differential mortality ascertainment or the type of cohorts represented in each country income group rather than true inequity in outcomes by country income group. Within this SAFA adolescent cohort, a detailed growth analysis is planned to further interrogate determinants of impaired growth in adolescents, and certainly a better understanding of outcomes in APH that are not retained in care is needed to appropriately compare and interpret estimates of mortality in this population. There is value in continuing to follow these cohorts of HIV-infected children that are aging into adolescence, as the current generation of APH may be substantially different to future generations that will have likely started ART far earlier during childhood and may be impacted by very different issues. I would like to acknowledge the entire Adolescent Project team who have given tremendous input into this project, as well as the International AIDS Society, SAFA, the Data Center at UCT, and all of the contributing networks, their study participants, and their funders. And I look forward to your questions.
So people on the side, please feel free to come and fill in seats over on the middle and on the right. Question here, microphone.
Thank you very much. Congratulations to a nice presentation. When you do a growth analysis starting before puberty and then entering into puberty, you are into some trouble, which is also the time of onset of puberty, etc. I think in the future you need to take that into account. Thank you.
Yes, thank you very much. So that's exactly why we're planning to specifically look at the growth in far more detail in this cohort, to exactly take puberty as far as we can into account and actually sort of the changes in trajectory and growth. Thank you.
Microphone here on the left.
Yes, thank you, Amy. My name is Lydia. I work with AIDS Healthcare Foundation. I thank you for the good work that you have presented to us. And my question about your analysis is about the grouping of the countries per income setting. Is it likely that some of the failures or that the data that you see, that the failure to pick up differences as per income status of the country is due to the misapplication or the misappropriation of income status per country. And my point here is with regards to the lower middle income countries. Is it likely that these countries are actually misplaced as lower middle income countries? And then my other question is about what was your null hypothesis in terms of grouping the countries per income status? Thank you.
Thank you very much. So we really do realize that grouping by country income group and using the World Bank classification for that is a very simplistic way of grouping these countries. Income is certainly not the only determinant of development in these countries, and there are far more factors at play. It was just a first effort to try and get a sense of in this enormous amount of data that we have from across the continent, how things might change depending on the level of resources generally available in those environments. So I think our hypothesis was certainly that outcomes would be better in upper middle income countries, and we expected that there would be more of a dose-response relationship, that lower middle income countries would have also had superior outcomes compared to low income countries, and we really didn't see that. The low and lower middle income countries were very similar. However, as you've highlighted, we had very few countries in the lower middle income group, only Cameroon, Lesotho and Swaziland. So this is potentially not very representative of lower middle income countries in general.
So we'll have two more questions. Center microphone first.
Thank you for a lovely presentation. I'm Constance Mackworth-Young from the London School of Hygiene and Tropical Medicine and Zambart. And my question is around mobility. We know mobility is a big issue in this population, and particularly related to loss to follow-up and maybe moving clinics. And I was wondering if you could take into account mobility in your analysis, and if so, how you did that.
Right, so we unfortunately don't know specifically about mobility. We know when there's been a documented transfer. We have that indicated in the data set. And there was actually a very high rate of transfer out as well, actually higher than loss to follow-up by 15 years of age in all three country income groups. So these adolescents are certainly moving around. We know there's a substantial proportion of them moving around, and there's probably far more moving around than what we do know about. The work around outcomes in adolescents that have been lost to follow-up is, thankfully, there's work now underway in pediatrics and adolescents to understand what the outcomes are for this group that are often classified as lost to follow-up. But from some very preliminary work in South Africa, we know that a lot of these have actually been silent or unidentified transfers, and that these adolescents have moved elsewhere and are actually still in care elsewhere, and that all of them, the loss to follow-up is certainly not mortality. But within this data set, we certainly can't tell for sure, beyond documented transfer out within the data sets, anything further related to mobility of the adolescents.
And final question.
Thank you, the presenter. It was quite a wonderful presentation. But I'm wondering, because normally children who are getting HIV probably are from the poor parts of each of those communities. So I was wondering if you went and analyzed the socioeconomic status of the individual children, how it will impact on your conclusion. Because the mere fact that I'm from lower, middle, and so forth, I don't think that represents what we know with which children normally get HIV. Thank you.
Absolutely, thank you very much. That's a critical piece to understand the outcomes of these adolescents. And unfortunately, we don't have that in this data set. This was an enormous collaboration that came together with a restricted number of variables that were merged into this data set, and coming from very, very different settings, some where there is very good data on socioeconomic status, and other data that came from very much just programmatic, routine sources of data. So unfortunately, we don't have that level of detail, but it is absolutely critical to understand this population and the outcomes.
Okay, thank you, Amy.
Thank you.
So we're lucky to have an obstetrician in our midst. So we introduce Professor Jan Sibut. She is an assistant professor in gynecology and obstetrics and epidemiology in INSERP, and she specializes in studies in PMTCT.
Thank you, Mo. Let me just open the files. So, hello. I would like to start by thanking the organizers for allowing me to present this work on behalf of the French perinatal cohort study group. We sought to evaluate the risk of birth defects among children exposed to raltegravir in utero in the ANRS French perinatal cohort. The disclosure slide, I have no conflicts. So why study ARVs and birth defects? There has been conflicting literature concerning some ARVs that are widely prescribed, such as efavirenz and zidovudine. And we have seen an increasing proportion of women treated at conception. On the figure, you can see the proportion of women treated at conception in France, which was 67% in 2014 and increasing regularly. Since embryogenesis occurs during the first trimester, this is of particular importance because most of these women treated at conception will be treated throughout the first trimester. There is also a wide range of drugs received at conception. You can see here all the drugs that were received at conception in France in 2013, and among these, raltegravir is now about 10%. There is to date no specific published literature on raltegravir and birth defects. There is one large report, the largest report to date is from the Antiretroviral Pregnancy Registry, which is an international registry, and they report on 263 children exposed in the first trimester with 7 birth defects, so 2.7%. And there is no difference with children exposed in the second or third trimester, which is 3.2%. There is also evidence of placental transfer for raltegravir, which makes even more important this study. Our data source is the French perinatal cohort, which is a national multi-center ongoing prospective cohort and includes 100 sites in France. In these 100 sites, all HIV-positive pregnant women are included, which represents about 1,000 inclusions a year, so a total of more than 20,000 mother-child pairs since 1985. It has been estimated that the coverage of the French perinatal cohort is about 70% of HIV-positive pregnant women in France. After delivery, uninfected children are followed until 2 years of age, and infected children are followed until 18 years of age. For the study of birth defects, the variables of interest were collected systematically at birth. In each birth questionnaire, there was a specific question concerning birth defects, and then at each visit that were happening every 3 to 6 months until 2 years or 18 years, all clinical events are reported. It's of note that there is no additional imaging on account of the study, and there were no additional investigations due to exposure in utero to specific drugs. We did the coding of birth defects according to the EuroCat system, in which minor defects are excluded. And exposure to raltegravir was categorized between earliest exposure in the first trimester or earliest exposure in the second or third trimester. We had a total of 479 children exposed to raltegravir between 2008 and 2015. You can see on this figure that the number of women taking raltegravir during pregnancy increased regularly until from 2008 to 2011, and then stabilized around 90 to 100 a year. This was divided into 140 who were exposed during first trimester and 339 that were exposed later during second or third trimester. Among these women, about 50% had only one regimen during pregnancy, and a third had 2 or more regimens, and about 18% had 3 regimens or more during pregnancy. Concerning the outcomes of pregnancies, there were 6 stillbirths, 2 late miscarriages, and no termination of pregnancy, and the rest were live births. 14% of children were born preterm, and there was 2% of twin pregnancies. For the preterm birth rate and the twin pregnancies rate, it's equivalent to the rest of the cohort. So for the rates of birth defects, We found among children exposed in the first trimester a proportion of 5.7% of birth defects, and for the children exposed in the second or third trimester, 3.5%, which is not significantly different. When we looked more closely at congenital heart defects, the percentages were 2.1% for children exposed in the first trimester and 1.2% for those exposed in the later trimesters, which was also not significantly different. This, the corresponding odds ratio were then 1.6% for children exposed in the first trimester compared to the reference, which was exposed later in pregnancy. So our conclusion is that there is no significant difference between exposure in the first and second or third trimester to raltegravir in terms of percentages of birth defects. We then looked at the type of birth defects. You have on the left column the type of birth defects for children exposed in the first trimester, and on the right, exposed in the second or third trimester. And I will just go over the details of those exposed in the first trimester. For congenital heart defects, on the top part, there was a hypoplasia of pulmonary arteries, an anomalous pulmonary venous return, and a patent ductus arteriosus. These were only taken into account if they were in a child that was born at term. For the non-cardiac defects, there were 2 cases of polydactyly, one posterior urethral valve, a kidney cyst, a splenic cyst, and a case of Down syndrome. So this shows that, moreover, we have no difference in percentages, and moreover, we didn't find a cluster of similar defects that could be associated with first trimester exposure. So the strength of this study is that it's the largest number of children exposed in utero to raltegravir with a homogeneous evaluation of birth defects due to our standardized follow-up for at least 2 years, and it's a multi-center national cohort. Our limitations is that we had no information on pregnancies ending before 14 weeks of gestation, as most women enroll after 14 weeks in this cohort. And we also did not, for this analysis, take into account other ARVs that were taken with the raltegravir, and we have no information on other non-ARV drugs during pregnancies. Our conclusion is that there is no evidence of association between birth defects and exposure to raltegravir in utero. These findings are reassuring in the context of prescription of this drug for young women with few therapeutic alternatives in France, at least, and continuous epidemiological surveillance of new drugs for the risk of birth defects is, of course, needed. I would like to end with thanking the ANRS, the promoter of the French perinatal cohort, and the steering committee and coordinating center of EPF, of course, all participating women and children, and our contributors. Thank you.
Thank you. So this presentation is now open for questions.
Hi, it was a very interesting presentation. I'm from Nepal. I'm a clinician. Did you adjust for the other hydrix during pregnancy, like diabetes, smoking, alcohol?
Do we have, your question was, do we have the information diabetes, smoking, alcohol?
Did you adjust for the hydrix pregnancy and diabetes?
This was a crude comparison, so we did not adjust. We can adjust on smoking, but very, very few women in our cohort are smokers, and we don't have the information on pre-existing diabetes, which is the one that could be associated with birth defects.
Okay, thank you. I'm Dr. Namisi from Makerere University. I was wondering, given that the birth defects are a little bit rare, and you are comparing the timing of the drug, why didn't you compare with the normal non-HIV? Because that would have given us the perceived risk of the drug. And I thought, if I were you, the next step would be to compare with similar women who are not on ARVs, because then there you'd see the actual risk. Thank you.
This is an excellent question. It's So our data source, the French perinatal cohort, only includes HIV-positive women. This is the first thing. And so we chose to compare first trimester versus second and third trimester because since embryogenesis occurs during the first trimester, we considered, as is done in most literature, that children exposed only in the second or third trimester would have been non-exposed during the first part of pregnancy.
Thank you very much. My name is Elena from Uganda, Ministry of Health. I wanted to know from you if you also compared the birth defects in relation to the ages of the mother, because we know that for some of the birth defects that you found, like Down syndrome, are found in the older mothers as compared to the younger ones. Thank you.
Yes, it's a very good question. The age of the mother was known in the cohort. However, we are currently looking more in any confounding factors that we can find. We have small numbers, and this is why we chose to show crude comparisons and not multivariable models. But this could be taken in the analysis, absolutely.
Okay, so thank you very much, Jian. So our last speaker is Dr. Sirintip. Dr. Sirintip is a research physician at the Pediatric Infectious Disease Unit in Thailand, and she's been directly responsible for the treatment of children in clinical trials at the site she works in.
Good morning, ladies and gentlemen. First of all, I'd like to thank the organizer for giving me this opportunity to present this work. I have no conflict to declare. As you may already be aware that the Hpv vaccine uptake has been inconsistent in resource-constrained settings. As a result of limited studies, it is unclear how well the vaccine would cover the common Hpv genotype infection in prenatally HIV-infected and HIV-uninfected adolescents and young adults in Southeast Asia. In order to address this question, we studied to determine the prevalence of HPV infection by HRVS9. HRVS9 stands for high-risk vaccine-specific type that are covered by nonavalent vaccine. In addition, we also look at the neutralizing antibody and the factor associated with orogenital HPV infection. Let me elaborate on how we conducted the study. This is a prospective cohort study carried out in Thailand and Vietnam. We recruit prenatally HIV-infected and HIV-uninfected female aged 12 to 24 years who were sexually active and naive to HPV vaccine. We exclude the adolescents who were being pregnant or having symptomatic STI or sexually transmitted infection. The HIV-positive subjects were matched to HIV-negative subjects by age group and the number of lifetime sex partners. There were three main parts of the study procedures. Firstly, the diagnosis of HPV infection by genotyping and antibody. The genotyping panel includes all vaccine-specific type in nonavalent vaccine. We obtained a specimen from totally 4 sites, oropharynx, cervical, vaginal, and anal specimens. And for testing by Roche linear array test, we also measure the serum neutralizing antibody against HPV 16 and 18. And this was done by pseudovirion-based assay developed by University of California in San Francisco. Secondly, assessment of behavioral risk. The participants were asked to complete a questionnaire using audio computer-assisted self-interview. And finally, testing for STI. The PCR assays for chlamydia trachomatis, Neisseria gonorrhea, and herpes simplex virus 2 were tested using cervical samples. The serum VDRL was used for syphilis screening. We used the descriptive statistics to summarize the subject characteristics. The Fisher exact test and Mann-Whitney U test were used for comparison between two groups. The point that I'd like to explain about is how we define HRVS9 or high-risk vaccine-specific genotypes. The 7 out of 9 types in nonavalent vaccine that are associated with cancers were considered as HRVS9, which are listed here: 16, 18, 31, 33, 45, 52, 58. The other 2 types that are only associated with genital warts, specifically HPV 6 and 11, were not included in the category. To assess the factor associated with orogenital HPV infection, we used multiple logistic regression. The orogenital HPV infection in our study was defined as either positive HRVS9 at any of the 4 sites or positive neutralizing antibody against HPV 16 or 18. I would turn to the table showing you the participant characteristics. The study recruited totally 93 HIV positive females and 99 HIV negative females. The age of the participants and the number of lifetime sex partners was similar between 2 groups. Concerning the sexual behavior, the HIV negative females had first sex significantly earlier at median age of 15. Among all STI, chlamydia trachomatis was most commonly found in both groups. Neisseria gonorrhea was more common in HIV positive females. And notably, HIV negative females were less likely to use condom when having sex. Next, I would like to draw your attention to this histogram. The HIV positive group is in blue and HIV negative group is in orange. The column at the right side showing you the prevalence of the orogenital HPV infection defined by either positive genotype or antibody. About 50% of each group was already infected by HRVS9. When we look into the difference between HIV status, whether or not they have more prevalence, we did not see the difference in the prevalence of HRVS9 and no difference in the prevalence of a positive neutralizing antibody either. Then we stratify the overall prevalence by age. We divide into 3 age groups: 13 to 16 years in brown, 17 to 19 years in blue, and 20 to 24 years in green. We try to find out if there was any difference among age group, and neither difference in the prevalence of HRVS9 type nor difference in the prevalence of positive antibody was found. I would like to point out that even we have a small number of the very young age group, at 13 to 16 years, and even no difference by HIV status was found, and no difference among age group was found. 60% of the very young age group already had HRVS9 infection. We also would like to know if any difference between HIV status at different sampling sites. The HIV positive group is in blue and HIV negative group is in orange. The HIV positive female were more likely to have HRVS9 at cervix, and this was significantly different. 37% of the HIV positive group and 23% of the HIV negative group already had HRVS9 at cervix. We did not see a difference at other 3 sites. This leads me to the final part of the result of the factor associated with orogenital HPV infection. The variable with the p-value less than 0.15 from the univariate analysis were included in the multivariate analysis. What we see is that non-HPV asymptomatic STI and the higher number of the lifetime sex partner were significantly associated factor with orogenital HPV infection. In addition, we look into the HIV positive group only by performing the subgroup analysis. We found that the higher viral load and non-HPV asymptomatic STI were significant factors. Of note, age at first sex and the condom use were not significantly associated factor with orogenital HPV infection. Our study has some limitation. Firstly, this is a cross-sectional data. Therefore, the age when acquiring HPV infection is not known, and we cannot distinguish between recently acquired HPV infection and persistent infection. Secondly, besides HPV 16 and 18, we did not measure the neutralizing antibody against other HPV type. So we may miss a proportion of the subject who only show immune response without positive genotypes. Just a quick recap of my main points. Half of vaccine-naive female adolescents and young adults had evidence of prior vaccine-preventable HPV orogenital infection. And while HIV-negative females were more likely to engage in high-risk behaviors, the perinatally HIV-infected adolescent and young adult had similar prevalence of HPV orogenital infection, but more cervical infection with HRVS9. Higher viral load and non-HPV asymptomatic STI independently predicted orogenital HPV infection in perinatally HIV-infected adolescent and young adults. The take-home message I would like to emphasize is the greater access to HPV vaccination is needed, particularly in early adolescents in the region to prevent future cancer risks. And on behalf of the participating sites, I would like to thank to all the patients and study staff at all sites in Thailand and Vietnam, NIH as a funder for this study, and the laboratory site from the University of California. Thank you.
Thank you. So I think the floor is open for questions. So I mean, just to ask, I mean, the condom use is quite low overall in the community. Why do you think it was slightly higher in the perinatally infected group? Was it they were counseled, or the condom use was very low overall, but higher in the infected group? Why do you think that?
Why can be explained? Well, I think perinatally HIV infected adolescents, they have been looked after by our clinic, and they have been very well educated on the safe sex and other things. So they have been more well educated in our clinic, I think.
Thank you for a wonderful presentation. Two quick comments to reflect on. One, sex being a very difficult topic. What is the social desirability of their response? Because if you're asking an adolescent, the girls will underreport, and the boys may overreport the sexual partners. So how did you tease that out? Number two is on your conclusion. You are saying the young ones should be vaccinated. But your figures say by the 10, the early adolescents, they have the highest prevalence. Does the vaccine treat if you are recommending that they are vaccinated? I thought you would think of trying to look backwards when probably they get infected. That's where the vaccine then will play. I think I would help. I'm Dr. Namisi from Mackay University.
Well, first of all, how we choose these adolescents, I would say some sites of our network face some difficulty to recruit these adolescents because from the ethical committee regulation, some sites not allow us to enroll the adolescents under 18 years. And in some countries, don't allow us to enroll the adolescents under 15 years because of legal impact. But still, we can find some, even only 20 of the very young age. And it is absolutely true that we cannot know the onset of HPV acquisition. But in our study, once we we get to know that they already infected by HPV. We monitored them for long term. For this study, we monitor for 3 years, and for some teenagers who have abnormal cytology or abnormal biopsy, we have the further management.
I think the take home is we want to vaccinate them as early as possible before acquisition, and not waiting for them to become infected. So if there's no further questions, I'd like to thank our panel for keeping to time and for an excellent discussion. And just to summarize, we've heard in terms of adolescents that unfortunately adolescents from especially low-income and low to middle-income countries that are far higher risk of mortality and growth outcomes. And we've heard that giving calcium supplementation and vitamin D had positive effects on bone mineral density, particularly if the baseline bone mineral density was lower in these perinatally infected infants. And lastly, we've heard in terms of adolescents that access to HPV vaccinations is extremely important in decreasing the risk of cancer acquisition of HPV serotypes. In terms of our neonatal work, raltegravir thankfully seems to be all clear in terms of birth outcomes, which is really good news for us as we move towards more integrase inhibitors. And from Harriet, we've heard that if we need to develop programs, we need to know who we're targeting. And if we target people who, in terms of our high-risk individuals, and know when they're going to be at home, is probably the most important thing. So thank you very much to all our speakers.